Hello, I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a great session on if you cannot have a joint replacement, what is the conservative treatment of knee osteoarthritis? What are the ranges of treatment? We have, I feel, a great faculty tonight and a good audience, and we're going to get the ball rolling with some introductions from the faculty. I'll start with Chris Varacallo. Chris, tell us a little bit about something about yourself and what you do, and where you're going.
Thanks, Ira. Happy Thanksgiving, everybody. Great to be here. Chris Varacallo. I'm located in Penn Highlands Healthcare in central Pennsylvania. I practice non-operative sports medicine, so a lot of these patients just land right in my lap, and I'm welcome them with open arms with lots of different treatment options. I've been in practice for about 10 years, and really over those 10 years have really developed a treatment algorithm to kind of address a lot of the different problems that can arise and the pain generators that can arise in these knee osteoarthritis patients that can't have joint replacement or want a joint replacement, can't have one, or don't desire one. And really, there's a lot of treatment options, and every year there's more and more treatment options that continue to come out. So excited to talk about this. I'm excited to learn and discuss and banter and argue and go back and forth. So thanks for the invite, and we can pass it on.
All right, Moby Parsons.
Uh, Thanks for inviting me, Ira, and happy Thanksgiving to everybody. I am a joint replacement surgeon. I do hip, knee, and shoulder replacement. I work in a very small kind of boutique practice with one other partner. We pretty much just do joint replacement surgery. We don't have the benefit of having a lot of ancillaries. We tend to refer out a lot of our non-operative management to people like Chris and adjacent practices that can do ultrasound guided injections and various other different non-operative treatments. That said, we do see a lot of people who are not ready for joint replacement, and so we do manage a fair amount of non-operative arthritis who maybe just aren't ready yet, or people who are just not eligible for surgery for a variety of different reasons. And I'm basically here to learn from Chris and John.
Yep. And John Richmond, JR, like to introduce yourself, please?
Well, thank you, Ira, and again, happy Thanksgiving to all. I'm John Richmond. I'm from Boston. I am a sports doc. I haven't done a joint replacement since the 90s. And if you practice in the same city for 40 plus years and you do a lot of knee arthroscopy and ACL reconstruction, you have a lot of osteoarthritis that you take care of, which I did. So I've uh, uh, chaired the original AAOS guidelines and the non-operative treatment of osteoarthritis and done several other guidelines. So I know the BS that goes with the guidelines, and I think hopefully we'll hear a lot of other things that don't necessarily fit in the official treatment recommended by the AAOS.
Good. I'm also going to surprise introduce Kevin Plancher. Kevin, you're on. I know you do a lot of knees and see a lot of people. I know we haven't always officially have you on as a panelist, but you are unofficially always on. So why don't you introduce yourself, Kevin?
To my amazement, a happy Thanksgiving, I guess, is the theme. Um, I'm honored to sit with Chris, JR, and Moby and everyone on, and you, Ira. I'm an orthopedic surgeon that started my life as JR, as a sports medicine doctor. But if you start in that way and you follow your patients long enough, and I trained at the Brigham and Mass General, you can shift to become an arthroplasty surgeon. So you can offer the whole menu, as I call it, and I like to offer the a la carte menu. I look forward to hearing to everyone and maybe challenging some of this to see what we can find that's best for patients, starting off with, I'm not sure there isn't a patient that can't have a joint at some point in their life if you maximize their health.
Yeah. Absolutely. So I'm gonna start with Chris, and I'm gonna ask the following question: Who are these patients? Who's the quintessential patient who is a great candidate who has osteoarthritis, let's say grade 1 to 2, but what are the reasons they're not having a joint replacement, and how do you, when it comes to you, how do you talk to them, and who are these people? Let's define the patient first.
Yeah. So, outside of the obvious reasons of they're not eligible for a joint replacement, these patients that have, mid to low level osteoarthritic changes, decrease in their physical function, increase in their pain, but don't want a joint replacement. There's a variety of reasons off the top of my head that really they give us. One in central Pennsylvania, time of year.
Hmm.
Um, I'm in central Pennsylvania, in the middle of kind of nowhere, a lot of woods. People like to hunt. They're not going to be down for hunting season, and that's what's going on right now. Whether it's winter time and they're scared of the ice, whether it's summertime and we have 4 or 5 months of summertime and they don't want to be down for that period of time because they're scared of the rehab. Some patients are scared to death, not only of the surgery, but of the rehab afterward. They've heard horror stories of how painful knee replacement rehabilitation is. So that's another reason that they may be scared of it. Maybe they're frankly just scared of anesthesia. Maybe they are have a family member that has had a knee replacement and had an infection and had a revision and a subsequent revision and now is on lifetime antibiotics or something of the like. So there's a variety of reasons that patients that are medically candidates for arthroplasty do not end up choosing that path. And that's one of the first things that I discuss with patients, maybe not with the lower grades of osteoarthritic changes, but if they are certainly eligible for a knee arthroplasty from a medical standpoint and a health standpoint, that's our discussion. Is that something that you want? And we get a lot of variety of reasons that they say, no, that's not what I want. And we have a whole gamut of treatment options to offer those patients that do not want the knee arthroplasty. But yeah, the reasons are kind of countless. I'm probably not even thinking of some of them that I've heard, but that's kind of the main ones that I hear.
Yep. JR, in your practice, originally, not originally from forever sports, but you mentioned that a lot of your patients, as they get older, when, at what point in time, sort of, do they come to you? Because sometimes we see these patients that have grade 2 osteoarthritis and they have 1 month of pain, and you know that X-ray looked the same a year ago. So what's your initial attack on these people, medically, when they come in?
Yeah, certainly the first attack is non-surgical. I would say that there, from the surgical point of view, there's really nothing that we can do surgically with the arthroscope for osteoarthritis,
Yeah.
except maybe if you're dealing with somebody who's got a real hot area that's bone marrow edema, that's painful to him and or her, and then that can be treated arthroscopically. But by and large, it's uh, try to get them to understand their problem, um, have them hook up with a good physical therapist who actually gets osteoarthritis, who isn't going to overload their joint, but is going to get them flexible and strong and give them good guidance as to how they can maintain their athletic activity. In my practice, they were virtually all doing something athletically. They may have played sports when they were younger. A lot of them were skiers, um, and they want to continue to ski. They want to be able to do those things. So I would take every modality that made sense to do and work the way up from weight loss if it was indicated, uh, PT, non-steroidals if they would tolerate it, and then eventually work into injections as a means to manage their symptomatology um, and have them maintain their activity with the hopes of delaying arthroplasty as long as it makes sense. Um, now we have good medications that help them lose weight, which is a great bonus. We've got great injectable things. My personal bias, because I worked with it and did research on it, is the use of extended release corticosteroids, because they can take that person who's kind of to the end of everything um, non-surgically and extend the duration before they need to go on surgically almost indefinitely, so that the extended release cortisone, um, use the trade name Zilretta because there's um, no generic name for it, because it's a combination of a microsphere and triamcinolone acetonide, um, that really makes a difference as far as management, and can be repeated on a regular basis.
Moby, I know you say you send out a fair amount, but you know, you're going to get a lot of patients who really are going to say, I'm not ready for joint replacement. What would you like people to go through treatment wise on those people? And what in your experience prevents them from what's their decision making of not going through a joint replacement or even a grade 3 osteoarthritis?
Yeah, so I mean, we go through the whole array of non-surgical treatment options with them. I mean, I'll just speak from experience. When I had bad bilateral hip osteoarthritis 10 years ago, I tried everything. I tried all the supplements. I tried, the sort of naturopathic anti-inflammatories that you could get if you boiled pineapple rinds in water and got the bromelain out of the pineapple rinds. I mean, you know, the fish oil from Norway, which was purported to be the best stuff that you could get. I tried it all, and I think all that stuff is not unreasonable to try. I think some of that stuff works for some people and some of it doesn't. I don't understand the physiology of it. And so, we sort of give people an array of all these different treatment options, the various different injectable things. And the other thing I say is, a lot of people, because our practice is very concentrated on joint replacement, people get sent to us, having been seen by others and managed non-surgically and told that they need to have a joint replacement. I see this quite frequently with hip replacements, actually, where people have maybe had a hip arthroscopy or they've had an MRI that shows that they have early hip osteoarthritis, or maybe they have a pincer lesion and they're in their 60s and they're not a great candidate for a scope, but they don't really have loss of joint space, and they've been told you need to get your hip replaced, and they come in to see us, and it's clear that they're in pain when they do certain things, but they're getting along okay. And interestingly, what I tell these people is I say, look, you're going to get a joint replacement probably at some point in your life. You're still functioning at a reasonable level. There's no urgency to do it at this point in time. You can maximize all these, non-surgical treatment options. You can go trash it. You can go run. You can go ski. You can go do whatever the hell you want. And when it gets really, really bad, you can come back and we can replace it. And it's remarkable to me how many people are so happy to hear that they still have that option to go out and be super active when they came into my office thinking that I was just going to sign them up for a joint replacement, and that was kind of the end of the road. And so sometimes it's just patient education about what the criteria are for when people really hit that tipping point. That was a Rick Mattson term when I trained with Rick. He loved this term tipping point. It's basically that point at which it's really game over for people where nothing else is working and it's just time to do something. And the other thing I say to people is, look, particularly people if they're in their 70s or if they're in their early 80s, they're relatively healthy, they have a decent social situation, is, one of the ways to look at it is you're healthy now, you're not getting any younger, every day that goes by, anything can happen. And so they have to take all those things into consideration, which I think is reasonable as you get older. Nobody wants to be doing this in their mid to late 80s or early 90s, unless they're extremely healthy. And so, we tend to try to really wait for people to hit their tipping point before we do it. And I'm no expert on all the biological treatments in our office because some of these um, injectables like Zilretta, if they're buy and bill or whatever, depending on your contracts, if you're part of a larger practice that has a lot of ancillaries, it may be easier for your practice to do that. When you're in a really, really small practice like ours, it's a little bit harder to do things like that and bill for it and collect on the back end. And so that's why I said previously we have a lot of great primary care sports medicine physicians in other practices in our community that we routinely will refer people to for any manner of these different injection options. We'll do cortisone injections in our office. We'll do, when it comes down to viscosupplementation, that's getting harder and harder to get reimbursed by insurance companies now. We use TriVisc, which is basically a direct-to-patient, cash pay, where we just say, look, TriVisc will sell it to you for $291 for 3 injections into each joint, and we'll use that for shoulders and knees. And the patient just basically hands out their credit card number to the company. They send us the medications, and we get them in. That's how we do viscosupplementation, which we still use. Um, so that's kind of a snapshot of how we do it.
Kevin, someone comes to you, medial joint arthritis solely, grade 2, and they're saying, treat me. 62 years old. What's your first line? What's your second line? What's your third line?
Wow. Okay. So I live in a strange world in Manhattan. So you have to know that every community is a little different. I appreciate what Moby said, but in my community, if you're past 56 and you're not getting your joint, you're getting a fourth opinion and you're probably getting your joint. So, not necessarily from me, but I'm just saying that's what happens. What Chris said, I'd like to go there. I'll answer you directly. Chris brought up where I think we all fail as physicians because he brought up so wonderfully the fear, the emotional part of any part of visiting a physician, whether it's for joints, infection, rehab, he said, painful, anesthesia, if it's golf season, ski season, hunting season, whatever he said. And so I think first and foremost, as Moby says he does, we have to educate our patients about reality, and we have to do a better job sometimes in doing some of those things. So a 62-year-old medial joint line, you didn't answer me one thing, that wants to play singles tennis, ski, and do everything and be fully active. Is that correct, Ira?
Not skiing, but I would say enjoys golf. Enjoys golf.
Okay.
Not pickleball, not tennis, not jet skiing,
Okay. So a more sedentary person that just wants to be activities day limit. So first line, I'm going to go where JR says, because they probably need a better conditioning program of physical therapy, and I will put them on meloxicam at the same time. Because I live in New York City, you said it was grade 2. They're going to get the MR, or they're coming to me with the MR in hand. So that's just a fact of life. So, and there's probably going to be some insignificant meniscal tear that's not causing their problem, assuming there isn't a meniscal tear that is radial, as JR will say, and not in line. My second line is, unfortunately, in New York, we will try their out-of-network benefits, but they will end up paying something for. I am a fan of liposomal of Zilretta injection. I do like the extended release steroids, and I'm not a fan of PRP as many of my colleagues are in New York City. I probably do a combination visco steroid. That's what Dr. Stedman taught me. He always did that years ago, the combination of the two. And there are some out there that are already pre-made combination. Uh, and step three is a conversation pretending I'm a dentist. If you really can't do that and you went to the dentist, they would never offer you dentures for a bad cavity. They would cap your tooth. And so we would look down the line, assuming they have near bone on bone. I don't know, Ira. If
50%, 50%.
so, okay. So if it's not bone on bone, my third line is wow. I'd hold out for my third line, but my third line, as you know, is ultimately not going to be a total knee. It's going to be a partial knee, a uni, when they collapse or they say they just can't do the activities they want.
All right, I'm going to switch over to Chris, but first I want to make a comment. Um, I Kevin works in the 12th congressional district in the United States, which is the wealthiest congressional district in America. I work in the 15th congressional district, 2 miles
course.
away, which is the poorest congressional district in America. So, and we have different types of patients. I have three groups of patients who never go for joint replacement. One is the never jointers. They're people who say, I'm never getting a joint. I'm never getting it. I don't want to talk about it. I'm never getting it. I'm never getting it. And remember, we're a closed urban population. No one leaves the South Bronx for their care. No one comes into the South Bronx for their care. Okay. So we are basically the Galapagos Island of orthopedics. The second group are the forever 62s. They're saying, I want to get it when I retire. I'm 62, I'm going to retire when I'm 65. When they're 65, they now want to retire when they're 68. When they're 68, so they keep on extending. And the last group I call the church ladies. They're the ones who come in and say, someone at my church had a knee replacement and not doing well, so I'm never going to have that. All right. So we have those are our never groups. I do want to say we are a safety net hospital, but we stock triamcinolone, we stock Zolretta, we have PRP, we have Iovera, and we don't do an upcharge for the patients, and we include it in the just the visit. And there's a lot of reasons for that. And I can go into that later, but we have a very big commitment to treat the community. So we take a little bit of a loss leader. We do about 500 of these type of people a year, but we see 50,000 clinic visits, so it gets absorbed. But I'm going to ask Chris, what is your this same person, this grade 2 osteoarthritis comes to you. All right. They moved out of the Bronx. They decided to go to rural Pennsylvania, become a Steeler fan.
Yep.
And
Ditching the Yankees for the Pirates, right?
right, Yankees for the Pirates. Mike Tomlin sends them over to you. And grade 2 osteoarthritis hurts like hell. They can't golf anymore.
Uh-huh.
And they're having really just trouble working around the house.
So yeah, this is the patient we see all the time, right? And I start the conversation with, what are your expectations? Because I've been I graduated from medical school in 2011, so I have far less experience, but I have enough experience to know that's a good place to start with patients. What do you want? What are you here for? What are your expectations with this visit? If sometimes patients, I think Moby had said it, sometimes they're looking for, oh, you don't need surgery. And then you can shift your conversation. Sometimes patients think they need surgery or just want you to tell you they don't need surgery. So we start with that. You have knee osteoarthritis. That's your pain generator based on your x-rays, your physical exam, your history. That's what's going on. What do you want out of this? What are we trying to get? And then we try to match our goals together. Fortunately, you guys hit on a lot of great treatment options that are available. And so that's where our discussion goes if we're talking something non-surgical. Doc, I just want to be able to function. I want to be able to golf. Okay, I'll match my treatment options with your goals. Here's what we have available. Assuming, all the modifiable risk factors are under control, their weight's okay, things like that. If they are overweight, we have a discussion about, let's refer you to our weight loss management clinic. Let's talk about things like that, which are excellent treatment options for them to reduce the weight. But if we're talking about something interventional, because by the time they get to our office, typically they want us to do something. They don't want us to just say, hey, you have some knee arthritis and, go find somebody else to treat you until you're ready for your knee replacement. So they want us to do something. So then we shift into what our options are. You have your injectable treatments. So we talk about, different types of injections. The immediate release corticosteroid. I love the extended release corticosteroid. I think it's an amazing product, really changed the game. Most patients are very excited to have an extended release version of the corticosteroid because they've had an immediate release somewhere along the way and that provided them short-term benefits. So that's an easy one to sell. We talk about viscosupplementation if their insurance is an appropriate one or will cover it. And so we have that discussion about viscosupplementation, how we're using that, why we would use that in your scenario. Then we shift into more what I think is really changing a lot of the game in terms of pain relief, increasing function, are peripheral nerve procedures. You mentioned the iovera, Ira. I do a lot of peripheral nerve cryoneurolysis for my patients. We talk about those types of more interventional procedures. We're extra articular. We're basically blocking pain signals temporarily, utilizing cold treatment for some of those nerves. And we have that discussion about, okay, here's a peripheral nerve blockade. We can freeze these nerves and give you some semblance of relief for a period of time. Also, neuromodulation. I've been doing neuromodulation for about a year and a half, 2 years now, which you can use in a variety of factors. Let's say they have extreme quad weakness or gluteus medius weakness. There was a paper a few years ago that talked about transcutaneous electrical nerve stimulation and the 6-minute walk test and how TENS on the quad improve 6-minute walk test against the control group. And so we're utilizing a lot of peripheral nerve stimulation in muscle weakness to improve function by using peripheral nerve stimulation in a motor capacity for the quadriceps ephemeral nerve, for the glutes on the superior gluteal nerve, and stimulating that muscle over a period of time to try to improve strength. And we're actually collecting data on this. And it's initially exciting, nothing analyzed yet. But really, you can kind of base your treatment on what they're expecting and then what you find in your physical exam. And fortunately, as I mentioned at the top, there's a lot of different treatment options that are now available and you can use and you can plug and play in terms of, okay, you have a knee effusion, so we're going to use this extended release corticosteroid, but you also have, some quad weakness. Let's try some physical therapy. Doc, I can't do physical therapy. It's too painful. Okay, we can try to stimulate this muscle for you using peripheral nerve stimulation. So we can, essentially use TENS technology on the nerve itself and stimulate that muscle itself and try to improve strength and then subsequently some physical function. So really, I just try to match their goals with my treatment options that I have available, knowing that they're a consumer. I mean, that's how we're treating people now. They're consumers. I educate them. I lay out the menu of treatment options. And we discuss about why one would be better than another. You have some weakness. You show them weakness on physical exam. Things like that. And then you kind of come together. If they can buy into the treatment, I feel like it's going to be a lot better accepted and going to be carried out a lot more efficiently. And they're going to have that buy-in and they're going to believe in the treatment. And I feel like a lot of what I do is just educate and talk about disease pathology, what is causing their pain, and then recommending the treatment options that really fit together with that. And fortunately, as the years keep passing, we keep getting more and more options that can address some of the deficits that we see.
Hey, Ira, can I pipe in and ask a few questions?
You don't even have to ask. You could just go.
I don't want to steal the show. Um, Chris, and this is gonna be like a five-pronged question here for multiple people. You mentioned gluteus medius weakness. I think that's an unrecognized thing. I think that a lot of people become quad dominant. Most of the exercises that we do, if it's elliptical, riding a bike, running, it tends to be unidirectional, and that tends to lead to a quad dominant type of pattern. And I think a lot of people as we get older tend to get this kind of core weakness phenomenon and weakness in our glutes that then leads to this quad dominant behavior. And so in my community, there's like one or two therapists that really, really understand this phenomenon of incorporating more than just sort of looking at the knee in a box. And I think that's really, really important, what you mentioned there. I want to backtrack, and JR mentioned if I see bone edema on an MRI, I can fix that with a scope. I don't know how to fix that, JR. When I see bone edema on an MRI, I feel like that's game over. Can you teach me what you can do with that? And then the other thing I want to bring up, and Kevin mentioned I treat people with meloxicam, and Chris, maybe you can chime in on this, is there's been a lot of really interesting discussion about the microbiome and its role in inflammation in multiple disease states and the role of NSAIDs in creating gut inflammation. And if you create inflammation in the gut, are you secondarily creating further inflammation? And are NSAIDs actually counterproductive? I don't know the answer to this, but I think it's really interesting. I think we're learning a lot about this as things move forward. So I'm just throwing all that out there. But JR, tell me, when I see bone edema on an MRI, what can I do for that?
So if it's focal and you're not dealing with an extensive area of it, you can with a combination of um, arthroscopic localization and um, a C-arm, you can put a needle in there and inject the equivalent of what you use for wrist fractures to supplement them. You put in a calcium phosphate material that generates a healing response. I don't think it's putting the material per se in there is the big go for it, but you generate a healing response, and it's pretty straightforward. Um, it works well if the person is not BMI above 35 to 40. It works well if they're not significantly malaligned. If you've got somebody who's got a really varus knee, that's going to continue to stomp on it, but it'll get it to heal, and it's pretty dramatic. It's amazing. It'll take care of their pain and buy them a period of time.
I'll give a little anecdote on this. When I had my first total knee, I had just a massive amount of bone edema in the medial femoral condyle, and I went to a couple of sports centric, people who were doing subchondroplasties or the technique that you just talked about, JR. The problem was it was just too much bone edema I had. It was a placement of essentially the whole femoral condyle, and it was extraordinarily painful. You know, and it's interesting how the total knee took care of that.
So
But
It really has to be focal, Ira, but
yeah,
the Moby, the subchondroplasty is the official term of it, and it works well if you pick the right people to do it on. And I had great success. I learned the hard way that you got to be careful with alignment and careful with the size of the defect.
Ira,
yeah.
I would agree to answer Moby. Sometimes you always question, is it the joint or is it the bone edema, as Moby says, that's causing the pain? And I too would say that there are patients that if they rest it, it doesn't get better, that a subchondroplasty, it's off target for today is the way to go, Moby. And there's plenty of products there now that do it. I think I want to talk about the gut, and then I'll throw it back to Chris. There was a very famous, he's passed away, Dr. Crone. His first disciple was Dr. Janowitz, a GI doctor, wrote a little book, and I encourage you because you're dead on. They say you can never cure an orthopedic injury if someone has a gut issue. It was written 25 years ago, and he was almost thrown out. So that if you have any irritable bowel, Crohn's, whatever it is, you can be a genius and you are not going to cure that orthopedic issue, he said. And so to that day that when I read that, I've always seen that people are in control. Because remember, I'm in Manhattan, so they all have irritable bowel. They live that way on Park Avenue. Okay. I have more. I don't want to do it. We're being recorded. So the point is,
But we have editors. But we have editors.
so I mean, all sincerity, you're on to something there. But I've used, I'm almost ready to release the article, meloxicam on my rotator cuffs, on my things when you're not supposed to do all the things that they said because it annoyed me. And so I've given only, and I have had success, but you're correct. Gut inflammation, and there's something there, really does affect our outcomes. And I think we have to start looking at it. So I appreciate you bringing it up.
No,
I
I
just wonder, because we're seeing more and more arthritis in young people, and granted, some of it may just be activity related or, people that got banged up early in life and had ligament reconstructions. But, I'm seeing women in their 30s and 40s without significant hip dysplasia that have bone-on-bone arthritis in their hip, and you just wonder this kind of food industrial complex, all this processed food. It I like again, I don't have any science behind it, but I just feel like it's got to somehow be playing a role in some of these sort of chronic diseases that we're seeing. And you wonder if part of the whole treatment algorithm going forward should be, and I think we'll get more sophisticated this as time goes forward, is in terms of targeting gut related issues. Maybe we can do genetic profiling. Maybe we can look at people's microbiome and figure out ways to optimize it to reduce inflammation. I think it's a burgeoning field, and I think perhaps arthritis may be one of these diseases that is somehow involved in this whole um, it- you know microbiome sort of gut related inflammation process. I don't know for sure. I think it's probably multifactorial. But I feel like, when I look back every year, I sort of get to the end of the year and I say, how many hip and knee replacements did I do, et cetera, et cetera. And, because we have a bundled payment program with commercials, we very carefully track the commercial joint replacements that we do. And it's amazing how many hip replacements I'm doing in women in their 30s, 40s, and 50s. And it's legitimate bone on bone arthritis without significant dysplasia.
um,
Hey, Ira, can you get us all, or maybe Chris and JR, talk about stem cells, how many times they repeat the Zaretta injection, how often they do the Iovera? I'd be curious just to hear
so I
more.
want to, yeah, I want to lead. That's a great question. I want to lead into that. First, I'm going to ask JR and Chris a question. If if long-acting corticosteroids, Zilretta came out first, if it came out first, like before triamcinolone, would anyone ever think of using triamcinolone, short acting? It,
Absolutely not. I mean, it's got all the upside of cortisone in that it's quick acting. The onset's typically within 24 hours. They say on the package insert 48, but my experience is that it's quicker than that if you drain the knee when you put it in. Um, and it's the duration of action is fabulous. It's when we did the multi-injection study, a bunch of the people 6 months out were still had great relief. The only reason they opted for a second shot is they knew that if they didn't get it then, they wouldn't be allowed to get it until they'd gone through a full year. So it's longer lasting. I personally, I have a gentleman who was my professor of pulmonology when I was a medical student, who went through 9 of them before he finally said, "Okay, I'm going to take the risk of having the surgery done, just because they were starting to lose their duration of benefit. They still worked great, but they didn't last very long." And he was bone on bone in 3 compartments. So
yeah, yeah, it's
I think
great.
Zilretta can be used multiple times, well beyond what the package insert says. Um, and it's so much better than a standard cortisone. There'd be no use for it. I wish it was approved for the shoulder and all the other large joints, because I'm sure it would be equally as effective in there. I do know that in the occasional use, because people have to fork over and pay for it out of pocket if it's in the shoulder because no insurer will. It works just as well in the glenohumeral joint.
That's,
Yeah, and I will echo that as well. And it maintains in the synovium. So you think about, you mentioned the gut, and basically we're talking more systemic effects on localized disease processes, right? So if you're talking about an injectable that stays in the synovial fluid, like Zilretta does, you don't get the peak plasma concentration spikes of the steroid, and so you don't have the neuroendocrine insults on that side of things, and it shows in the diabetics they don't have the plasma glucose spike that happens with the immediate release injectable steroids, Medrol or triamcinolone or the like. And so you think about, systemically addressing, a localized disease process, especially, and don't not even to mention those diabetics we're trying to say, get your A1C under control so you can have a surgery. And then we go ahead and inject, immediate release steroid into their system and their sugar goes to 400 over the next 3 days. And so we're really kind of we're counterproductive in that realm. But I agree. I think if the extended release triamcinolone came out first, I'm not sure the immediate release steroids would have an effect other than intramuscular in the urgent care setting for a
yeah.
rash.
Is there a minimum duration between the Zilretta injections? Is it 3 months, 6 months, or user discretion?
Uh, the I've never used it closer together than 3 months, Moby. And in my personal experience, it always lasts 3 months or maybe 2.5 months if you really got bad OA. It doesn't, you don't get the full duration out of it. But by the time the 2.5 months it wears off, they call the office and they get in. They're at the 3 month mark. So I've done it that way. But it turns out with most of these people that um, are relatively mild disease, if they're not bone on bone everywhere, you're it's very unusual if you don't get 4 to 6 months out of it.
That's a huge amount of time, for these people. It's um, like I said earlier, I had a triamcinolone hip injection about 3 or 4 weeks ago, and it's beginning to wear off. That's not long enough time, you know.
The problem with the hip IRA is that it's not in the hip. Your pain is not a synovial disease.
Yeah,
Your pain is the pain is coming from the bone, and unfortunately the Zilretta is not terribly effective. But my experience with the shoulder, there's a lot of synovium in
yeah.
a significantly osteoarthritic shoulder, so it wipes out the synovial pain generators.
That's a great point. Chris, I'm going to give a shameful plug to an article in JOEI, um, which did talk about cryoneurolysis and deep and superficial genicular nerve. I just want to briefly split to that and then go back to corticosteroids a little bit because I am an early injector. Yeah, I'll do meloxicam for 1 month and then bring them back 1 month to see the result, and then I'll do early injector, and we'll very frequently go early on Zilretta. Okay, but tell us about the technique related to cryoneurolysis and how important technique is in getting good results from cryoneurolysis.
Yeah, correct. So crown neurolysis has really changed. I've done it for about 6 years now, 6, 7 years, all over the body. Knee is kind of where I first implemented the technology and the treatment. Discussing crown neurolysis is, you talk to people, it works great. You talk to some people, it's not as effective. You have to treat the nerves, in particular. So if the knee's not numb, you didn't treat the nerves, and the treatment is you can't decide if the treatment was effective or not. I always liken it to it's like treating carpal tunnel by not releasing the transverse carpal ligament or partially releasing it and expecting it to get better. You didn't actually treat the problem. And so, lysing the nerves and creating a crown neurolysis, a freeze ice ball on the nerve, and providing that treatment is crucial, which doesn't
Right.
happen all the time. So that's one thing. The other thing too is this is really what got my mind thinking about, we're talking about systemic effect, and I think there's different probably phenotypes of osteoarthritis. There's multifactorial reasons people have pain from knee osteoarthritis. And what really hit that home is some patients that I've treated with this technology, with this cryoneurolysis technology, have end-stage knee osteoarthritis. And I will treat their superficial nerves. And what we're talking about for this is femoral cutaneous branches and saphenous branches. So superficial nerves that are fascial and capsular and have nothing to do with the periosteum or the deep bone or the posterior knee. And patients getting relief. And so that really opened my eyes to some of these patients, with their knee osteoarthritis. It's not a mechanical issue. It's not bone on bone. It's maybe capsular mediated. And that's why you would inject something like Zilretta and they would get relief, even though you're not addressing at all the mechanical issues associated with their knee osteoarthritis. So technique is really important, and treating specifically what type of arthritis they have or what's mediating the pain related to their arthritis is extremely important. And that's something we don't know right off the bat. And that's why, Kevin, when you were asking the question, what's your first line treatment? What's your second line treatment? He's sitting there scratching his head. It's like the hardest question he's ever had to answer, because we don't have someone coming in with, hey, this is the phenotype of my osteoarthritis in my knee. This is what's going to best work for me. It's going to be, a gut health program. It's going to be an exercise program. It's going to be a brace. It's going to be an injection. It's going to be cryoneurolysis. It's going to be neuromodulation. Until we have that, we're going to be able to say at the first appointment, this is going to be the best thing for you, or, none of this is going to work. You need a knee replacement. And I can tell you this based on what is driving your pain. So technique is extremely important, and what is actually driving their pain is extremely important. And sometimes it's a little bit of trial and error. You try one treatment and they get maybe a moderate or no effect at all. And then you talk about some other types of treatments. And so that case report is a great one. I've seen that in my clinical practice, and I'll echo the effects of peripheral nerve cryoneurolysis. It's extra articular, which is really nice. We can do it around joint replacements and not be intra-articular, not affect delaying their knee replacement or things of the like, and really provide them, the patients, with some decrease in their pain so they can maintain physical function, so they don't decompensate prior to surgery. If they're waiting for a long time for their knee replacement, or they don't want to have the knee replacement. But technique is everything. If you don't lyse the nerve, you're not going to get the effect. You could potentially get the effect if you lyse some of them. But that's one of my first questions when someone tells me that the peripheral nerve cryoneurolysis didn't work. Was their knee numb? And if the answer is no, then the treatment wasn't conducted effectively. If the answer is yes, then maybe it's a different pain generator that we need to address.
Great.
I think that is totally, totally fascinating what you just said about different pain generators and osteoarthritis, and, you know, the trial and error effect of trying to determine that. And Ira, this is why I love these get-togethers that we have, is because we share ideas on this. And, as orthopedic surgeons, we tend to be a little bit, wearing like, if it's a nail, hit it with a hammer,
Right.
you know, and I think that to me is really eye-opening, that's the way you look at it, to think that there could be different pain generators, whether it's bone, whether it's synovium, whether it's mechanical, whether it's biological, and targeting different things. I mean, I think that's the beauty of these sessions here, is that we share this kind of information because we all look at it from a different angle, and that's a really, really valuable insight.
That's great. And like all the Joey sessions and like life itself, it marches on like a blink of an eye. We're at 8:56 already, so I'm gonna ask the faculty to say a couple of parting points. I'll start with our guest faculty member, Kevin Plancher. Say a couple of parting points, and we'll go through the list. I'll go through Kevin, Moby, JR, and have Chris bring us home at the end. Just a little summary.
I want to thank you, Ira and Joey, for allowing me to be a guest faculty suddenly. Thank you for that unprepared remarks and joining the faculty. I think there are so many solutions that are available today if you're not desiring operative intervention for osteoarthritis. An extended release, corticosteroids, should be considered as after physical therapy, a first line. And I think it can be a valuable piece in your armamentarium, and that listening to others with other modalities and listening to your patient to understand what their realistic goals are is so important.
Okay, Moby, I know you gave a somewhat summary statement before, but let's couple of minutes to summarize.
Yeah, I mean, I think what I just said about considering the various different pain generators and talking to your patients, trying to figure out what their goals are, uh, you know, paying attention to what their level of osteoarthritis is, and whether or not it's something that can respond to a sort of comprehensive, well thought out scheme of non-operative treatment. I mean, I always tell my patients, look, arthritis is not a fatal disease. It's not like 99% occlusion of your left main artery. It doesn't kill you when you walk down the stairs tomorrow. And so I think patient education is a big part of this. I think, as I've learned tonight, considering possible different pain generators and how best to target those. Um, for us in our practice, because we're kind of focused on joint replacement, we really focus on the patient education aspect of things and trying to maximize non-operative treatment. I look forward to where this microbiome thing goes. I think that's going to be really interesting. I think we have a lot to learn there. And yeah, I appreciate everything that Joey has done to educate me in these great discussions. So cheers to you,
Thank you.
Ira.
Thank you. JR, just a few comments.
It's great to see that I'm not the only person that thinks there's other causes of pain generating than bone on bone. So the synovium is a big pain generator when we're talking away of the knee, and I think that's why extended release corticosteroids are a should be a prime tool in an armamentarium. And the biologics have some benefit. I think PRP can work reasonably well. It's not a cure. It doesn't change the articular cartilage. It's just an anti-inflammatory. Um, but it's typically several injections, and you only get 9 months out of it, maybe 6 months, 9 months, and so it's an expense, and it doesn't have that quick onset like Zilretta does. And we still don't have stem cells or pluripotential cells. They're getting there, and they may be available soon. Um, but things are changing rapidly, and and right now, if you're going to use injectables, then the extended release corticosteroid is, to my mind, the best choice.
Chris, as a resident expert in phenotype and all else, um, why don't you bring us home for the night and some parting words and thank you, and then I'll say my thank yous.
Absolutely. And I'll thank you, Ira, for just creating the space to have this discussion when the invite came out, what was it, a month or two ago. I was excited because, like I said, these are the people I welcome with open arms. Fortunately, because there are treatment options. So I personally think this should be part of every orthopedic practice, whether it's internal or a strong referral-based network of using the technology that's available for treatment of pain and osteoarthritis in patients that don't desire or can't have a knee replacement. That's the wave of what's coming through. And so developing a strong referral network or internal network of referrals to really allow your patients to have access to all the treatment options that are out there, really being a champion for their pain relief. taking ownership of that and really directing patients. Because, like I said earlier, our job is to educate. The patients can make a decision. If they buy in, they're ultimately going to have a better outcome, whether that's with non-operative treatment or with the operative treatment. And sometimes patients just need to exhaust all the non-operative measures to then move on to a successful operative outcome. So, once again, thanks for having the forum to discuss this. It's exciting. We're tipping the iceberg with the osteoarthritis, and exciting to see where this moves in the future.
Well, listen, I want to thank the great faculty tonight. It was wonderful. Once again, as we know, Prince Spaghetti Night is Wednesday night in Boston, and it's also Joey night. So we're really glad to have everybody here tonight. This was a very important discussion, one that has taken on fire the last 5 to 7 years. And I'm so happy that we got everyone together. So I want to say thank you and good night.